So I'm Kate Yeager, and I have the honor of introducing our speaker today for our research roundtable. That's Dr. Ursula Kelly. She's going to be talking to us about her research on trauma-sensitive yoga for PTSD related to MST in women veterans. We'll learn all about that. So some interim findings. You'll see all the information about Dr. Kelly here, and I peeked at her resume. She's one of those people that you wonder how she does all that she does because she's doing lots of different things. A little bit about her educational background. She got her BS with a major in nursing from University of Massachusetts in Boston, then got her Master's of Science from the University of Massachusetts at Worcester, and then went to Boston College to get her PhD. She is a certified psychiatric mental health nurse practitioner and has a lot of great skills with that. I know it's very supportive of our community and helps us with those skills. But she's also the nurse scientist at the Emory VA Medical Center. So since 2009 to currently, she does that, as well as is an associate professor here at the nursing school. It's an integral part of our faculty, teaches in the PhD program, mentors a lot of students, does a lot of great things. So, and also, she's also, does practitioner work.
Looks like it's me.
Grady ER. So I could go on and on. You should check out her publications, really interesting publications, but I will go ahead and hand it over to Dr. Kelly. If everybody can make sure and mute while she's talking, you can I'll try to monitor the chat board to see if there's any pressing questions, but hopefully we'll have time at the end for questions also. So Dr. Kelly, thanks for sharing your research with us today.
Well, thank you. And I'm really thrilled to be here. So I was thinking as you were reading off all of my degrees, how many degrees it will take me to learn how to share a full slide view in Zoom. But that notwithstanding, I'm very happy to be presenting, and I cannot see all of the attendees in my little VA setup here, but I thank you all for being here. My 732 students, thank you. This was not mandatory from my perspective, but I'm glad you're here. And I think we may also have some guests from the Shepherd Center, and so I'd love to welcome you as well. And I see Terry Haywood on, and those of you who don't know her, you hopefully will get to know her in the coming years. She's my project manager for this endeavor, who has brought us through nearly to the conclusion of the study in a beautiful way. So what I'm really hoping in this presentation is sort of to hit a number of high points, thinking about presenting for the School of Nursing community. I know that there are a bunch of people at the school who know my name and know I'm at the VA, and beyond that sort of wonder what the heck I do. So this is a way for me to share really my life's work for the last 8 years or so at the VA. For those of you who are interested in yoga, I'll talk about that. And then there's some really interesting science questions in here as well. And for those of you interested in women veterans and women veterans health and kind of what's going on and what are the VA's priorities around that, I hope to be able to touch on that as well. So forgive this presentation mode, but this is what we'll do in the interest of not losing more time. So I have pulled out just a few names of the many, many people involved in this study to highlight. I mentioned Terry already. Melinda Higgins has been the statistician on this project since 2012. And so she knows all the ins and outs, and I would be completely lost without her. We also have a Portland site now, so we have staff from there. We have psychologists, cardiologists, sleep medicine, psychiatrists, a whole range of people involved. And Dave Emerson from the Trauma Center is the one who developed Trauma Center, Trauma Sensitive Yoga. So from now on, I'm going to just say TCTSY. And by that, I mean Trauma Center, Trauma Sensitive Yoga. And we'll talk about what that means exactly. I've been exceedingly fortunate to get VA funding a few times for this. Of course, I must say the contents of this presentation do not represent the views of the U.S. Department of Veterans Affairs or the U.S. government. And though the government is now getting closer to representing my views, so that's a great thing of 2021. So just in addition to sort of what I'm hoping to highlight for this audience in particular, the way this presentation is laid out is really talking about the problem, a little bit about like why yoga for this problem, why trauma sensitive yoga, and then some really, to me, profoundly exciting results. And I'm bubbling with energy and delight to be able to share them with you. So many of you know that military sexual trauma is an official term by the VA that refers to sexual assault while serving in the military or experiencing ongoing threatening sexual harassment while serving in the military. And on average, the most common studies, women veterans are reporting 20% experienced sexual assault and an additional 20% experienced ongoing sexual harassment, threatening in nature. And of course, like any sexual trauma, we expect that those rates are actually much higher. And the current rates for men are more in the like 4 to 5%. And of course, those are probably 10 times that in reality. 20% of women veterans experience severe or moderate to severe symptoms of PTSD and are diagnosed, though not all get treatment. There are some studies that show that half of women who experience MST go on to develop PTSD. I think that's sort of where my work at the VA has been focused, and where we're moving more and more will be to look at what about the half who don't, and what about that? And resilience in the way that I know that many of you who I can see on this screen are also looking. But it's still nonetheless a continuing problem. It is as present now, as far as we can tell, as it was decades ago, although of course the politics and the discourse around it now are very, very different than they were previously. So the VA is a leader in PTSD treatment, I would say nationally for sure, and really internationally. And there are several evidence-based treatments that have been rolled out in the VA to treat PTSD, without really distinguishing between PTSD related to combat trauma, to military sexual trauma, or other types of trauma that happen. So these are evidence-based treatments, they're gold standard, they're top line, but the reality is that they're a little limited. So when they work, they really work. But dropout rates, as you can see here, range between about 30 and 44%. That's of people who start. There are a number of people who are not willing to attempt those therapies because they're difficult, disruptive. Usually people's symptoms of PTSD get worse before they get better. And as you can tell from the names, exposure therapy, prolonged exposure, and cognitive processing therapy, they basically involve going back to the trauma to talk about it, relive it essentially, to sort of come out the other side. So when it works, but when it doesn't, it really doesn't. And I'm realizing as I'm looking back and forth that most of the time I'm not looking at the screen, but I figure you're probably looking at my slides, so I apologize for that. One thing that has been happening in the VA, as well as in our culture in general over the past 10 to 20 years, is really a growing use of complementary and integrative health therapies. In the VA, it's just burgeoning with the rollout of the whole health program. And while there's a lot of program evaluation being done in whole health, which offers a whole variety of CIH modalities, there's actually not a lot of rigorous research specific to yoga for PTSD. It's growing, you'll see lots of pilot studies, but to our knowledge, the study that we're wrapping up is one of the largest studies in terms of sample size that's been done, and certainly the largest with women veterans, which is really, really exciting. For those of you not in the VA, it's helpful to know that there's something called the Evidence Synthesis Program, where scientists in the VA synthesize the literature, and these types of documents are available outside of the VA. So particularly for doctoral students, you might want to check that out. There are this most recent one in the bottom right, just came out in December 2020. They cover a wide range of topics, not just those I've selected here, but a variety of chronic illnesses, etc. So I already mentioned yoga is really being used more and more as a clinical intervention for PTSD. And so not yoga for wellness, yoga for feeling good, but really as an intervention for PTSD. And that's in the VA and outside of the VA. Though again, not really evaluated rigorously, certainly within the VA. Of the studies that are out there, the evidence is very promising. It looks like there's something about yoga that really does help symptoms of PTSD and helps people feel better and function better. But how that happens, we don't know. So what the mechanisms are, that's really unclear. So is it the breathing component, for example, or is it the physical movement, or the meditative component, or something else? So that is an area that I'm certainly exploring, as are a number of other people. And so far, we're mostly theorizing about that. So there are a few frameworks out there for understanding, well, like, why yoga for PTSD? Why not some other type of talk therapy? Or, wouldn't medication alone do it? As with all things psychological, there are a lot of approaches that we can take. And so we're really, for me, here's where I get to explain why yoga. So I have two very clear in my mind and on paper theoretical frameworks for why yoga for PTSD. And this is really important in terms of understanding not just how it works, but what it might have to offer in terms of being an alternative or an adjunct or a precursor to those treatments that do work, like cognitive processing therapy. So maybe yoga works for a certain type of person, someone with a certain symptom profile or historical experiences, and therapy works for another, or some of us are just more drawn to cognitive processes than sort of more internal processes. So my favorite one is that yoga is groovy, but really that's not how you get funding. And I think that is true, but we're coming at this really from a perspective of yoga. I believe, as do some others, that the mechanisms of yoga are the direct, are antithetical to the mechanisms involved in PTSD symptomatology. So all of the autonomic nervous system dysregulation that happens with PTSD, HPA axis dysfunction, the inflammatory response. I know a number of you study either chronic stress, chronic stressors, and certainly the inflammatory response. And really, I think that this is a big key here. So the theory for why yoga would work for PTSD here is really one from a psychoneuroimmunologic perspective. What PTSD does, what it activates, yoga can deactivate, or dysregulation and regulation. Specifically, I'm not going to go through this in great detail, but specifically PTSD activates the sympathetic nervous system. So you get increased heart rate and cardiac output and blood pressure, and yoga modulates the sympathetic nervous system, inducing a relaxation response. Similarly, trauma itself and PTSD decrease heart rate variability, which is something that we want. We want the heart rate to be able to change to meet the circumstances, right? Whereas yoga increases heart rate variability. So that's yoga. Well, great. But why trauma sensitive yoga? Why not Bikram yoga, hot yoga, Anusara, any, local gym yoga. Why trauma-sensitive yoga? Well, trauma-sensitive yoga, because embodiment is important. And so yoga, specifically taking trauma into account, being an embodied practice versus, for example, something that's purely meditative, I chose an embodied modality knowing that sexual trauma results in people checking out of their bodies. And so from my perspective, having an embodied treatment could work to bring people back into their bodies. This is what we got. We kind of got to be in them to move through the world. That's particularly important with sexual trauma and complex trauma. TCTSY is about interoception. It is all about simply noticing what's going on in the body. And that's a premise in a lot of yoga, and you might hear teachers say that in yoga classes in the community, but in this case, it is purely about that. It is absolutely not cognitive. It's just about noticing what's happening in your body, feeling the sensation of your feet on the floor. In addition, it's about having choice and control. And so the language of how yoga classes are run is all about that. It is completely invitational language. This is not someone who's running you through a series of poses to get to an endpoint. This book, Overcoming Trauma Through Yoga, is a really accessible, I find a great introduction to trauma-sensitive yoga for those of you who are interested in learning more. Importantly, unlike the evidence-based therapies that I've talked about that are cognitive in origin, TCTSY thinks about trauma from a bottom-up approach. So cognitive therapies are a top-down approach. They say trauma causes cognitive distortions that lead to emotional distress. And so if we change those cognitive distortions, we'll improve that distress, right? We're saying trauma happens to the body first, and eventually makes it to the frontal, the frontal cortex and the frontal lobe and the midbrain. But it happens to the body first. And so accessing the body is a more direct way to addressing the trauma. The themes involve, as I said, making choices, being in the present moment, having the experience of taking effective action, even if it's as simple as sort of raising your arm to a certain point, wherever you choose at your comfort level. Doesn't have to look like anything in particular. There are several theories about how TCTSY works. I've sort of described those as I was explaining this bottom-up approach, and the themes of the courses. This is another way of presenting that information, but really trying to grow the interoceptive parts of the brain so that it's really growing that internal awareness. Being able to feel and sense one's body and creating safety in that space, which of course was taken away with sexual assault. Okay, any critical time-sensitive questions before I move on to actually run through the details of this study now that I've fully oriented you? And Jessica, you'll have to tell me since I can't see the chat.
Right, yes, there are none in the chat currently. Okay.
All right, great. So the objectives of this study, and so we call this Project Stress Less, and it's Project Stress Less 2 because we did a pilot, feasibility and pilot study first, actually a few of them. These are the objectives straight from the grant proposal. So really to evaluate the effectiveness of what is now called TCTSY to treat PTSD and comorbid depression, because the overlap and comorbidity is just about 100%, not quite, but almost 100%. In addition, chronic pain and insomnia, which are two really intractable symptoms that often accompany PTSD in this population, social functioning and quality of life, and then to look at the mechanisms of action of yoga. So in this study, we have a whole bunch of objective data, including heart rate variability, EKGs, cytokines, acoustic startle response, sleep studies. I think that's it. Today, I'm going to be presenting primarily the PTSD outcomes for the results. So this is an RCT. It started off as 4 years. We got an extension pre-COVID to add a site and continue enrollment. We added Portland, yes, in February, just a month before the shutdown. So we moved everything that was face-to-face in terms of these face-to-face group format interventions that you see described here on the slide, as well as data collection to virtual delivery or virtual format for interventions and data collection. So that's a conversation either for the question and answer time or for another day. But this was originally designed, and for most of the study, this was all face-to-face with sessions held at the VA. We have collected just a tremendous amount of data, starting from baseline mid-intervention. And so for yoga, that's after 5 weeks of treatment. For CPT, that's after 6, because they're manualized, and one is 10 weeks and one is 12. 2 weeks post-intervention and 3 months post-intervention, which is a decent follow-up time frame. There are a few studies that managed to go out as far as 6 months, but we did not think that we would be able to keep people engaged for that long. We have clinician-assessed and patient-reported outcomes on PTSD symptoms. We also used the BDI for depression, looked at insomnia, a whole bunch of other sleep measures and related measures. And you can see Dr. Higgins' amazing data analysis plan outlined here. So we have actually finished this study in terms of enrollment for the intervention, conducting the interventions, and getting all follow-up data collection. I'll tell you a little bit later about an additional wave of data collection that we hope to do. But in terms of these objectives, we're done. We've run all of the interventions and collected all of the data that we're going to specific to that. So again, this sample was women veterans with PTSD related to military sexual trauma. 201, they had additional traumas. I don't recall anybody who only had MST as a lifetime significant interpersonal trauma. We've recruited throughout the Atlanta VA healthcare system, and then again added Portland. Our enrolled sample was 201, so almost got to the target enrollment of 210, but not quite, but I'm quite happy with that. In Atlanta, we enrolled 152, and our intent to treat analysis is based on 104. I'll talk about that in a bit. Portland had great enrollment just in a fairly quick period of 49. And I don't have their final numbers handy, but I think for follow-up data, we're probably around 20. This population in Atlanta is primarily African-American, so 90%. You'll see a wide age range here of 22 to 71 years old. And so really something that was appealing to a wide age range of folks. As with many veteran populations, this sample was highly educated with a mean of 16 years. And PCL, again, that's the PTSD symptom measure. So greater than 50 at baseline, which puts them in the severe symptom category. I think it's probably very difficult for you to see this CONSORT chart. So what I'll do is highlight the really important numbers. And again, this is just for Atlanta. So to yield that sample size that I just described, we assessed over 460 people for the study. Many were excluded for not meeting the inclusion criteria. But of 152 people who consented, only 104 came for baseline data collection and were then randomized. So we had, a third greater than 30% attrition before we even started the interventions. That's consistent with clinical practice of people referred to trauma programs for PTSD treatment, but nonetheless shows you how many, as a scientist, as a researcher, with this population, how many folks you need to reach out to and talk with to get people into treatment. We can talk more about that if you have questions. All of that was to yield at 3-month follow-up. So quite, several months later, we had 47 out of the 104 we had 3-month follow-up data on. Okay, now here's the really fun part. Here are the results, and I'll make some points about these slides as we go through. So what this slide shows you, on the left is the yoga group, on the right is CPTC. And what we see is that, of course, in the first session or two, attendance was at its highest. And then for yoga, after the first 2 sessions, people sorted themselves out, and attendance pretty much hovered at 60% throughout the rest of the intervention, so 10 weeks. Whereas what we see in CPT, it was basically a gradual decline. This is really important when we think about treatment engagement for a problem, PTSD, that has as one of its core characteristics avoidance, right? So one of the challenges of PTSD is just getting people to come into treatment and stay there. A treatment can't work if people can't or won't come. So what's really important is for us in this is that we were able to maintain about a 60% session attendance, which, for this type of problem and intervention is really strong. This is a numbers-laden slide, of course, but let me walk you through it. So this is using CAPS, which is clinician-assessed PTSD symptoms. And so that's gold standard. It's not self-report. It's up to the clinician to really make an assessment of this. And so what we see are, what's the best way to walk you through this? So you can look at the mean scores as they drop for the TSY, that's the yoga group, and CPT. There's a really nice drop in scores. What is very exciting is the effect sizes. So for clinical intervention, it can be particularly useful to look at the effect sizes, and our effect sizes for yoga were over 1, making them large throughout. With really clinically meaningful differences, that's the right-most column, from baseline. And so what you see is that by midpoint, the yoga group had improved by 51%. And by the end, 64%. So they improved a lot and then kept improving. Whereas in CPT, you see that by midpoint, that improvement was much less, but by 3 months follow-up, they were doing as well or better. In terms of the model, essentially the punchline here is there were no statistically significant differences at 3 months follow-up between the 2 groups. I'm going to keep going through the results, and then we'll come back to that when we have time to have a discussion. And I think Melinda will love to jump in as well. This is sort of a study design issue that's come up. So no statistically significant differences between groups, meaning both interventions performed comparably, both with statistically and clinically significant improvements within groups. So both groups got better to more or less the same extent. Trauma-sensitive yoga and the current evidence-based gold standard treatment delivered as such. Okay, another way to see this more visually, and this is definitely how I am better at seeing the result. So the dotted line is CPT, the solid line is yoga. And so what you see again is the yoga group had a greater improvement at midpoint and then really continued to improve, where the CPT group got to a point, stayed that way until 2 weeks post, and really it was 12 weeks after they finished the intervention that they actually showed more symptom improvement. This is another way to look at them side by side in terms of the symptom improvement trajectory, which I think is important. So the time effect being highly significant means over time, both groups improved significantly. No group effect, meaning there was no difference between the groups. PCL is patient-reported PTSD symptoms. Again, you'll see that for CPT, that dotted line, they barely budged 6 weeks into a 12-week treatment, where yoga decreased really significantly. Over time, CPT group continued to improve, as did yoga to a different extent. Side by side, again, just giving you a different view of the symptom trajectory between the two groups. Same thing, both improved over time, no difference between the groups. Another way you can use the CAPS is to say whether or not at the end of treatment people continue to meet the diagnostic criteria for PTSD. In a perfect study design, you would note that both groups should have started at 100%, right? That's the inclusion criteria. One of the criteria was that people had a PTSD diagnosis. There are some sort of explanations for that, but I'd be remiss in not pointing that out. And what we see is that for the yoga group, by the end, 60% had lost their diagnosis. It's also important to note that 40% still met the criteria, right? So it's not the be all and end all, but it's something. And it's something powerful, as these data show. I wanted to really focus on PTSD today, but I couldn't resist including depression scores. Neither of the interventions in this study, TCTSY or CPT, I think maybe someone needs to mute, are designed for depression. However, we see that depression scores improved significantly in both groups, which is a major win from my perspective. Insomnia. Okay, here we go. So I know many folks on this call are interested in studying sleep and insomnia in a variety of populations. The dotted red line on this chart is the cutoff for the Pittsburgh Sleep Quality Index of problematic sleeping. What you see is that both groups maybe got a little bit better, but not anything that was either clinically or statistically significant. It just didn't budge. And you'll remember I said earlier, insomnia or sleep disturbances are one of the really intractable symptoms that are part of the PTSD picture and the depression picture. Very, very hard to treat. It's another conversation for another day. And we haven't been able to extract all the data yet that we need to from the VA electronic medical record, but I do think that this will have something to do with the really high prevalence of obstructive sleep apnea in this population, which is very difficult to treat in general, even more difficult to treat in the context of PTSD, even more difficult in the context of PTSD related to sexual trauma. People are not really, wanting to have obstructive equipment around their face and neck. Many women who have experienced sexual trauma would find that triggering. So we will be looking at that more carefully. There are interventions in RVA here and in others to really try to work with that population in particular to improve adherence to OSA devices, obstructive sleep apnea devices. But what we see here is yoga didn't help sleep, CPT didn't help sleep. Anecdotally, there were a few women who had profound stories, who had been in yoga, had profound stories of being able to sleep for the first time in years, and falling asleep in the yoga class despite typical hypervigilance when out in the world. But that's anecdotal, and collectively the data show us that these interventions really didn't do much for sleep. So we have a lot to learn in this area in particular. Okay. Oh, this is so good. I'm getting through so quickly. We'll have time to talk. Yay. So limitations to this study. Attrition was high for data collection and intervention sessions, though much better for yoga, which supports the original rationale of the study, which is that current evidence-based treatments were lacking for some people, right? Recruitment was definitely challenging. There are a whole bunch of reasons for that. Among them were not what people might think of and what I had thought might be a problem, which would be, for example, African-American women in the South thinking that yoga was some, you know, incongruent with their faith or religion and belief system. That wasn't a thing. If anything, recruitment was challenging because people needed to be willing to be randomized to not yoga. So there was a great interest in yoga in this population, but a number of other challenges. That is the reason we added Portland as a naive site and a site that didn't have many studies going on with women veterans at all. They were able to enroll a really large cohort in a short amount of time with help from the Atlanta-based team. The sample size, given the attrition, the sample size for outcome measures is certainly smaller than our intent, starting with an intent to treat of 104 in Atlanta, getting down to 58 at 2 weeks post-intervention and 47, 3 months. Nonetheless, still making this one of the largest yoga studies for PTSD with veterans, and the largest with women veterans. We had not collected sexual orientation and gender identity data initially. We are collecting that now. Athena Sherman, one of our postdocs, is working on that. It's important to note here, there were no unanticipated adverse events. So frequently, if you look at yoga studies, it's pretty rare that people will comment about the safety. But we had no safety-related adverse events related to yoga or CPT. But to point out here, no unanticipated adverse events. Given the symptom profile of this population coming in the door, we anticipated all kinds of things. So yes, people were hospitalized with suicidal ideation, but that was not unanticipated. That is part of the clinical picture in the population that we're working with here. So conclusions. TC-TSY and CPT had comparable outcomes at 3 months post-intervention follow-up. Yay! Huge, right? If we have time to talk about this, we can talk about what it means for me to say that versus what I thought I could say at first, which was that TC-TSY was as effective as CPT. And so this is a study design question that might be interesting to some of you and like hugely tedious to others. So we'll leave it at that. But to say they had comparable outcomes. So TC-TSY performed comparably to current evidence-based treatment. I included an evidence-based treatment as the control or comparator condition so as not to waste my time, right? I didn't really want to spend 4 years and $1 million saying yoga is better than weightless control or yoga is better than health education. How about how does yoga do compared to this thing that when it works, but it often doesn't. So that's really the rationale for using an evidence-based treatment there. Retention was greater in TC-TSY. So we had 60% retention versus 35% in CPT. So what that means is that 65% of the people who were randomized to CPT did not complete treatment. And 40% of yoga folks did not complete treatment. I already pointed out TCTSY group showed improvement at midpoint, which is probably contributes to the greater retention. If you're doing something that's really, really hard, like CPT, and you're not getting better, it's going to be more likely that you'll drop out than if you're doing something that may be hard or may feel great and improves your PTSD symptoms more quickly. We found that TCTSY may be effective in treating depression that is comorbid with PTSD and perhaps depression alone. There's another study to be done there. Beautifully, that both interventions were sustained at 3 months post-intervention, which I'm really thrilled about in terms of yoga. It doesn't surprise me for CPT because it's all about learning new ways of thinking and practicing that. And so people tend to get better and better at that with time. There was a part of me that wondered if yoga would be similar to exercise, where it's effective, but only as long as you continue to do it. And we do have data, not collated, but we do have data about what types of yoga, if any of what they learned in the yoga intervention, they continue to use in that follow-up time period. But nonetheless, really exciting to see the sustained effect there. So implications are that this study really shows that TCTSY is certainly cost effective. We can deliver it in group. It is yoga facilitators. They are highly trained, but not as expensive as psychotherapists or social workers or psychologists. This is certainly scalable and really could be implemented in the VA nationwide. It may be an effective treatment alternative to PTSD psychotherapy, which, as I've said multiple times, is not universally acceptable or effective. And certainly we need to do more research to look at, is it best as an alternative or as a precursor, as an adjunct to psychotherapy, and exactly how does it work? And we have those data to continue to look at. Next steps, I think I'll skip through this because we're running into some glitches, although we are hoping to do one more round of data collection with all of our enrolled participants to see how they're doing now, which would be at various time points from their involvement in the intervention, because we can go back as many as 4 years probably, but also to see, to try to collect data from a wide range of people in our study about the impact of the COVID pandemic, and particularly in Atlanta and Portland for different reasons, the racial discord and protests and the political climate, all of 2020, how it's affecting their current psychological well-being. And then again, I sort of have to figure out, do I do another multi-site trial or an implementation study, or just convince the powers that be that this is a great thing that will work? And that's it. So amazingly, I got through this with 16 minutes of time for discussion and questions. And I would love to hear your feedback, and thank you all so much for your attention.
I want to thank Ursula for just an incredible presentation. What a wealth of information you have. What a great study. Congratulations. I know
Thank you.
It's easy, but congratulations. There were a lot of good questions in the chat.
Oh boy, okay, indeed.
People want to just ask their questions, or should I read them? I think Melinda started us out. You want to?
Yeah, Ursula, I think you addressed my question in one of your last slides, which was thinking a little bit about what we could do relative to the combining of yoga and CPT, because with yoga, we saw that immediate response at midweek to 2 week or 2 week post. And then CPT in some instances did continue to get better, but admittedly that was for the 30 or 40% of the people who actually stayed
Right.
to 3 months. But that combination might do a lot for both improvement in outcomes plus the lessening attrition. So that was just, I didn't know, but you sort of said it in your slide. So
yeah, if if I had to guess, I would say I think that the most effective combination, so to speak, would be at a minimum to start people in TCTSY, to really have them have the experience of being in a safe space, in a safe group, to learn interoception and some of the self-regulation skills that come with that, so that if they then do CPT, they've brought those regulation and interoceptive skills with them. The other would be to really do it sequentially, meaning do yoga. If you feel great at the end and you're good to go, great, go with God. If not, then you have those skills to bring with you into CPT. I think as we dig into the data more, Melinda, we may be able to identify for whom which intervention seems to work better. One thing that Melinda was able to pull out from the data was the only difference in the first pass for the Atlanta cohort in sort of the profile of people at the beginning who did better with what, is that people in CPT, people who had a higher sort of cognitive distortion picture to their PTSD really did better. And that makes sense. It's a cognitive therapy. So it still remains to be seen. Some of the things that I hoped that we would see, like sort of the hyperarousal picture at the beginning, maybe they do better with yoga. We don't see that in the self-report or clinician assessed data. Maybe we'll see that once we really are able to look at all of our objective data. But we haven't even gotten there yet. So now I've stopped sharing my screen, so I'm happy to sort of look at these questions quickly. Susan Brasher asked, can you talk about dosage or frequency of yoga as an intervention? Thank you, Susan, that's a great question. So the intervention was once weekly, and the sessions were 60 minutes on average, but in reality, they were shorter at the beginning because they were cumulative and they would add more yoga forms as they went on. So I would say in reality, the sessions were probably more like 45 to 65 minutes once weekly. We created videos with our teachers that we then shared with participants at midpoint so they could use those videos at home. We did not actually try to capture in any kind of detailed way how often they were using those videos, because my experience in the feasibility and the pilot was that was a work of fiction when people handed those sheets in. And so I thought, no need to do that, just provide this as an option. So the exact dose, we don't know, but that's manualized for TCTSY, hence the 10 weeks and the 12 weeks. So it was more minutes per, more minutes of treatment in CPT. I'm less concerned about that as what the treatment looks like and sort of getting people through it. Okay, and yep, Melinda, I answered your question. Andy asked, have you teased out sleep data by age? No, and I think that's a fantastic idea. Thank you for that. Melinda, are you making a note of that? Thank you, that's great.
Yeah, admittedly, we have just barely started looking at this data, so. We
have just started, although we have disseminated. So we have one publication on just the PTSD outcomes in press pretty much as we speak. And RF 201371, welcome. And some people in yoga continued to practice and some didn't. And I don't have those data for you today, but I can get them if that's important for your work. Melinda, let me get through these other questions and then we'll see if we have time to get into this non-inferiority trial versus RCT, which kept us busy hitting the books and the literature to discuss with the manuscript reviewers. But while I'm scrolling through, if anyone wants to unmute and just ask a question, please feel free. I'm not trying to keep you all waiting while I read.
Ursula?
Yes.
Ursula Kelly.
Susan Brasher.
Hi, great presentation. I love it, as always. I was curious, as I just heard you mention sleep and heard throughout the presentation, but noticing that there may be sleep differences, was there data collected on medications, like including melatonin, to kind of see what impact that might have in it?
That is a fantastic question, and I'm laughing because we have access to the medication list.
Oh, great.
We reported those. I am a nurse practitioner × 2, but in terms of this research design, people are on so many medications that we cannot possibly control for that. On the other hand, particularly since you mentioned melatonin, that is a great thought, because in the VA, so people who are eligible for services, the med lists are long because many of them have multiple chronic illnesses. But as I have been reviewing them one at a time to try to have a system for categorizing the med data, I'm also seeing that they're on multivitamins. Melatonin is commonly prescribed, vitamin D, calcium. So they get OTCs as prescriptions because they can get them filled in the VA pharmacy. So if there is anyone on this call or any colleagues that you have who would like to do a deep dive on the medications, there's so much. There's so much there. They're also on a bunch of cardiac meds. And so we're looking at heart rate variability and all of that response, in addition to pain meds. Remember, this group, many, not all, had chronic pain. So lots of people on NSAIDs. So what does that do in terms of looking at the mechanisms of action?
But the fact that you have access to that is really key, as far as when it started. So if you're seeing effects here, if that medication's been on the list since 2015, then you can more closely isolate. So
Ursula, can I add one little thing?
Please.
So one thing that Ursula and I've been looking at from a psychometric and measurement point of view is that, especially in this population, there's some interesting response profiles that happened with a lot of this data, one of which is the PSQI. And those of you that use that for looking at self-reported sleep quality, a key piece of that is knowing your approximate bedtime and wake time. And for a lot of these women, they had no idea. Their sleep was all over the map. So, and sometimes they didn't know truly when they fell asleep because they would just sort of grit it out. So anybody that wants to do a deep dive into even the self-reported sleep data, let us know, because I think there's a lot there.
Absolutely. Absolutely.
Menopausal status, the comments about menopause are really interesting. Thanks.
Ursula, first of all, congratulations. I'm so excited to hear about your results. You've been in data collection the whole time I've been at Emory as a student. It's so fun to see it coming to fruition.
You were born, Carrie, since you were born.
No, not even close. Thank you though. I mean, I'm feeling young today. But now, I was thinking that you were collecting some biological markers as well, and I don't think I saw those data. Are you still looking at that, or was that a wash? What happened with that?
Oh, we haven't honestly, we haven't even looked at those data yet. So we have cytokines, CRP, and then for Portland, so by blood draw here in Atlanta, but in Portland we're actually needing to do those by dried blood spot, because we had to do virtual data collection. So we won't actually be able to compare those samples because it's a completely different method of collecting, the body product. So yes, we have cytokines, CRP, heart rate variability, acoustic startle response, EKG, and sleep studies. And we'll be able to pull, for example, sleep study results. Were people referred, what was their diagnosis? Were they referred for treatment? Are they adherent? You know, if and when we can get to all of those data. So it wasn't a wash yet. I will be, I know a number of people on this call and elsewhere are waiting on the cytokine data. I think it will be interesting. I will be impressed if there's a story to tell there, because what I see is that there are so many influences on cytokines that we couldn't possibly have controlled for. I mean, we couldn't even collect meaningful sleep actigraphy data because of the incredibly disrupted sleep. So some thought that these cytokines are under any kind of controlled condition would be a fallacy. So we'll see. And you're muted. Okay.
So Ursula, this is Sudeshna.
Hey.
So are the results based on the full sample of 201, or is it just the Atlanta cohort?
The results that thank you. The results that I presented today are just from Atlanta. And those are the data that we have in press. And we're, I think it's probably this week that we'll be able to combine the data sets. They finished data collection in Portland at the end of December, and then we're going through some of the tedium of cleaning really complicated psychiatric interviews. We did a mini, not as many of you would think of as a mini mental status exam, but a mini psychiatric interview for comorbid psychiatric illnesses, for example, depression, other anxiety disorders, a whole range. And so we'll also have that information as well. There's a lot here. So no, it will be really exciting to combine the two data sets and see what it looks like, but also to compare them, because the Portland sample is, I forget exactly, probably 97% white. A little bit of, different culture out there. But if we're able to do that, so yeah, I think it'll be, it'll be interesting.
Mm-hmm. Yeah, and combining them would be interesting too, because you have a slightly modified intervention. It's not modified, but it's a different modality, right? So you might, again, get interesting questions from reviewers about combining them.
Yes, absolutely. In fact,
based on prior experience, yeah.
No doubt. And our site PI in Portland is taking the lead on a publication around, changing this whole study to virtual methods in terms of data collection and intervention. We've had a lot of discussion about the yoga intervention in particular as a virtual delivery. And there are definitely some very compelling positives to that, and some cons. But again, if you think about PTSD and avoidance, for people to be able to be in their own home and logging in and not using their video so no one can see them, so they don't feel watched, and they're able to be in their own space and just sort of tap into this shared experience, even through a computer screen, anecdotally was very positive for some people. And Kalisha, I see your comment there. Thank you. We'll follow up on that. And Susan, it looks like I need to teleyoga like Ken's telesavvy, indeed. Well, given that we don't know when we'll all be able to get out in the world again, or if when we're able to, everyone will want to, I think having virtual option it's great. It's great from sort of the psychological perspective that I already described. It's also great just from logistics. This population was working. Many of them were working. And so to get to the VA for 5 o'clock on a weekday was pretty much a nightmare logistically. And so virtual delivery, I think, really has some benefits.
Okay, it's 1 o'clock, so I want to give people that need to jump off ability to do that. But if y'all want to continue chatting, I've got a 1 o'clock meeting, so I'm going to jump off. But I do want to just thank you again for just an incredible presentation and lots more work to do. Lots of fun.
Well, thank you, everybody, for attending.
Thank you.
Great job, Ursula.
Thank you, Ursula. Thank you, everyone.
Bye. Thanks, Jessica. Thanks, Melinda.
Welcome. Bye, guys.